what we know and what we don't.
It's my pleasure طبعا ان انا ابقى معاكم النهارده. انا عارف صاحيين بدري واحنا عددنا قليل، فايتس يعني it's an interactive session. احنا طبعا our experience في الكوندكتيف سيستم بيسنج في مصر مش عاليه، بس معانا دكتور نعيم I think ان هو عنده experience في الكوندكتيف سيستم بيسنج، فاحنا it will be some sort of a discussion. طيب what we know and what we don't about the conductive system pacing. الحقيقه انا حبيت الكيو دي جدا. سقراط قال the true knowledge exists in knowing that you know nothing. So actually this is true for everything. It's not for the conductive system pacing or the micro or the electrophysiology. The true knowledge when you admit that you know nothing, and actually what we know is a drop in the ocean of what we don't know. So this is back for you. So what we know about the conductive system pacing, it's very simple. It's the idea that you try to capture the conductive system of the heart because it's rapidly conducting. So probably it will abolish any evidence of dysynchrony like the right ventricular pacing or in the patients with left bundle, etc. So the idea to capture any point of the conductive system starting from the His bundle, either proximal or distal His, and then you go through the left bundle branch or even the right bundle branch, the distal left bundle or one of the fascicles of the left bundle. All of this is the conductive system pacing as we know. It can be divided to His bundle pacing or left bundle area pacing. This is the new modality we are dealing with. And actually, I like this conductive speed very much. So the conductive speed, the conduction in the Purkinje system is 4 meters per second in comparison to the conduction inside the muscle, which is only 0.3 meters per second. So you can imagine how slow the conduction in the ventricle when you pace the endocardium. So it's definitely, or it's logically that pacing through the conductive system would be better for synchronization of the heart in any patient. But still, we have some vague points. We don't know everything, of course, about the indication of conductive system pacing. Would you implant a conductive system pacing for every individual or not? This is a question. Whether the conductive system pacing can replace the conventional CRT or not, this is another point. The second question about the implantation. The implantation process is not the normal implantation we know about the right ventricular and the right atrial leads. It's a little bit different with special requirements. How to verify the capture and endpoints, the complication and the long-term data. I will go very rapidly through everything. So the basic indication, it's very appealing to put a conductive system pacing in every individual instead of the conventional pacemaker. But actually, the only reason that you could put a conductive system pacing instead of right ventricular pacing is that you fear from the pacemaker-induced cardiomyopathy in this patient and then the dysynchrony. And actually, the right ventricular pacing causes dysynchrony. We know this, and cause cell apoptosis and later on myofibril derangement. So it is deleterious for the left ventricle. But although the right ventricular pacing do this in every patient, but not every patient is complaining from pacemaker-induced cardiomyopathy, and not every patient is complaining from heart failure. So we need some predictors to predict whether this patient will be a pacemaker-induced cardiomyopathy or not. One of these predictors is the percentage of RV pacing. When it's more than 20%, we expect that the patient can go through a pacemaker-induced cardiomyopathy. The presence of a very wide QRS complex after pacing more than 140 milliseconds, this is one of the predictors as well. But although you might have all these predictors and the patients will not develop a pacemaker-induced cardiomyopathy. So probably developing more accurate methods to diagnose the pacemaker-induced cardiomyopathy will give us a clue for which patient you can implant a conductive system pacing instead of the conventional pacemaker. Second, for the sinus node dysfunction, for example, you have no additive benefit of the conductive system pacing at all because you are usually pacing the atrium and it will conduct normally through the conductive system of the heart unless you expect progression of the disease to the conductive system of the heart. So the indication will remain in the patients with a conventional pacemaker that develop a conductive pacemaker-induced cardiomyopathy, so you can change to a conductive system pacing instead. For the CRT, for the patient with heart failure, the CRT is the only method up to this point of time that is proved to deal with the dysynchrony, to correct the electrical dysynchrony, the CRT, and is supported by a large number of trials. And all of us know that the presence of dysynchrony in the form of left bundle usually carries poor prognosis even in comparison with the same ejection fraction. So the left bundle itself it's a disease. that is only corrected by the CRT up to this point of time. And of course, this is the guidelines. The CRT is the first line in the patients with left bundle more than 130 millisecond and the ejection fraction below 35%, and supported by more than 20 years of trials and more than 20,000 patients starting from the late 90s. But the left bundle pacing emerged as an alternative for the CRT in some patients, but we lack some important points. This is the largest registry of left bundle branch pacing in Europe. It's the MILUS registry. Although the MILUS registry is the largest, but still we have a very small number of patients. The mean age is 74. Only 27% of these patients are patients with heart failure, and the left bundle is only 22.4%. And look at this, you have predictors of failure, the presence of broad QRS complex, the presence of heart failure, and depressed LV ejection fraction. So the success rate for the heart failure is only 76%. So still, we need some improvement in the left bundle area pacing to be an alternative for the CRT in these type of patients. But still the guidelines, the American and the European guidelines state that the CRT is the first line of therapy for this patient, but in case of failure to deliver an effective CRT, you can try conductive system pacing, including the left bundle area pacing in these patients. This is the American guidelines. So the CRT is the class 1, and then his bundle or left bundle area pacing in the patients, you cannot deliver an effective CRT for them. This is the same guidelines. And then we go for the implantation. The implantation is not that simple. You need, usually you need an EP system to define the His and to define whether it's a selective or non-selective capture. And then you have to do some maneuvers to ensure that whether it's a selective His bundle capture or non-selective His bundle capture, and aided by the fluoro, we can do some injections. So it's not as simple as the conventional right ventricular pacing lead we know. And this is the left bundle pacing. You go slightly deeper in the ventricle, and then you direct your introduction set to the septum, and then with slight manipulation or rotation of the leadless lead we have in here, the Medtronic lead, and then you are either penetrating the septum or just doing nothing. And you have some maneuvers to ensure that you are going through the septum, like the fixation beats and the change in the impedance. And then you should start pacing in this side to ensure that you have a good capture of the ventricle or not. So it needs special setting and tools, electrophysiological experience, not for everyone. And we know that in Egypt we have non-electrophysiologists implanting pacemakers a lot. Leads and introduction system are very peculiar. So what's available in Egypt is the Medtronic lead, this pacing lead, but I know that we have a style-driven lead from Bytronic and Boston as well for the conductive system pacing. And the introduction set, I think it needs some improvement because it was not initially intended for the conductive system pacing. How to verify the capture and endpoints? Actually, for the His bundle pacing, it's rather easy, especially if the patient is narrow-complex. You try to get a complex similar to the patient narrow-complex before implantation. And the selective His bundle pacing, usually there is a latent period between the pacing spike and the complex. For non-selective His bundle pacing, there is no latent period. There is something like a delta wave and then the QRS complex. But for the left bundle, this is the algorithm to define His bundle pacing. But for the left bundle area pacing, it's rather complex to define whether you are pacing the left bundle itself, you're pacing the left bundle area, or they're pacing one of the fascicles, or even it's a deep septal pacing. So it's not easy to define whether you are truly pacing the left bundle area or not. Sometimes you end pacing the right ventricle from the septum, or the left ventricle deep in the septum, or you even perforate and go inside the left ventricular endocardium. So it's not easy to define. And these are the complications. Actually, the procedure perforation is 3.7%, and then you might have some delayed perforation later on. The threshold is a problem because with the His bundle pacing, usually it's high and unstable threshold. With the left bundle, it's better. The dislodgement is there. There is no instance of stroke even with perforation, but I mean it's written in the complication to be taken in consideration. And also the extraction, I think the extraction will be a problem, especially if you are perforating the septum to the left ventricle. So there is multiple observational study that denotes that the left bundle pacing could be an alternative to the CRT in case you cannot deliver effective CRT, but there is no well-randomized trial. We are waiting for the PROTECT heart failure trial that will show, will compare the left bundle area pacing to the CRT. What we are missing, the long-term data, the prospective randomized trial, the evidence in heart failure and mortality reduction. So my conclusion, conductive system pacing is a promising and more physiological, of course, pacing technique, but not for everyone and not for every conventional pacemaker. CRT, still the gold standard in the patients with electrical desynchrony heart failure, but if you cannot deliver effective CRT, you can try left bundle or the conductive system pacing. Large prospective comparative data are still missing to modify the guidelines and show long-term mortality benefit in these type of patients. And this is my final quote, to know that we know what we know and to know that we don't know what we don't know. That's the true knowledge. Thank you very much.